For decades, women walked into respectable clinics seeking relief from exhaustion, anxiety, and sadness and walked out having experienced something their doctors did not even have the language to name. What was happening on those examination tables was not healing in the way medicine understood it. It was something far more revealing about ignorance, power, and denial. This is not a French story. This is not rumor. This was accepted science, taught in medical schools, practiced openly, and defended with confidence. And once you understand it, it becomes impossible to look at the history of medicine or women suffering the same way again. In the Victorian era, medicine presented itself as rational, disciplined, and moral. Doctors wore authority like armor. They claimed to understand the human body, the mind, and the boundaries between illness and health. But beneath that polished surface lived a contradiction so profound that it reshaped lives while remaining invisible to those enforcing it. This story matters because it exposes how cultural blindness can corrupt science. It shows how deeply held beliefs can override observation, logic, and even direct physical evidence. And it forces us to confront a quiet truth. Suffering is often prolonged not by malice, but by certainly the dangerous confidence that we already understand what is happening. What follows is not meant to shock for the sake of shock. It is meant to reveal how an entire medical system misunderstood women so completely that it built an industry around a fiction and never questioned it. In 1859, a well-respected woman in London known to us through preserved case notes as Mrs. Whitmore visited her physician with complaints that were common, yet troubling. She struggled to sleep. Her nerves felt constantly on edge. She experienced mood swings, irritability, sudden bouts of sadness, and moments she described cautiously as episodes. Nothing about her life suggested scandal. She was married, socially proper, and respected. Her doctor did not search for external causes. He did not ask about fulfillment, emotional isolation, or desire. He did not question the structure of her life. He reached instead for a diagnosis that had been used for centuries: hysteria. To modern ears, the word feels insulting, even absurd. But in Victorian medicine, hysteria was not fringe theory. It was foundational. It appeared in textbooks, lectures, and formal diagnoses. It was considered a legitimate disorder with legitimate treatments. The treatment prescribed to Mrs. Whitmore would today be recognized instantly for what it was. But at the time, it was framed in sterile language. She was placed on an examination table. Modesty was preserved with sheets. Oils were applied. The doctor performed what he believed to be a therapeutic pelvic massage until she reached a state recorded in his notes as hysterical paroxysm. This was not secrecy. This was standard care. To understand how such a practice became normalized, we have to go back far earlier, long before Victorian repression gave its structure. The concept of hysteria dates back to ancient Greece. The word itself comes from hystera, meaning uterus. Greek physicians believed that a woman's womb could move freely within her body. When dissatisfied, neglected, or unfulfilled, it was thought to wander upward, pressing against organs, disrupting balance, and causing illness. Plato described the womb as an animal inside an animal, desperate, restless, demanding satisfaction. The prescribed cure was marriage and pregnancy. In other words, a woman's health was believed to depend entirely on reproduction. Over time, the literal belief in a wandering organ faded, but the idea that a woman's body, and especially her reproductive system, was the source of her emotional and psychological state never disappeared. It simply adapted to new language. By the Renaissance and into the early modern period, hysteria expanded into a diagnostic catch-all. Any symptom that lacked a clear explanation could be placed under its umbrella: anxiety, melancholy, irritability, fatigue, loss of appetite, excess emotion, lack of emotion, sexual interest, lack of sexual interest. There was no way to escape it. By the 19th century, Victorian society reinforced the belief that women were inherently fragile. Their nervous systems were considered delicate, their emotions unstable. Their biology was believed to dominate their behavior in ways men were supposedly spared from. Prominent physicians wrote confidently about this. Dr. William Acton, one of the era's most respected medical authorities, famously stated that most women were fortunately not troubled by sexual feelings at all. This belief was not questioned. It was assumed, and this assumption created a catastrophic blind spot. When women presented with symptoms we would now recognize as frustration, repression, emotional neglect, or unfulfilled desire, doctors interpreted them strictly as pathology. There was no conceptual framework for female sexual need, so relief was treated as cure without understanding its nature. Pelvic massage became the solution. Doctors described it as a mechanical intervention. The goal was to induce paroxysm, a release of built-up nervous energy. They documented muscle contractions, flushed skin, deep relaxation, and emotional calm afterward. Patients often reported immediate relief. Physicians genuinely believed they were treating a disorder. The procedure was time-consuming. Some doctors complained in journals about the physical exhaustion it caused them. Treatments could last an hour or more. Dr. Russell Thackertrawl noted that inducing paroxysm was one of the most tedious procedures in clinical practice. This complaint would eventually lead to innovation, not from insight, but from fatigue. But before that, hysteria became an industry. By the late 19th century, it was estimated that a majority of women in urban centers suffered from hysteria in some form. Clinics advertised relief from female troubles and nervous exhaustion. Entire practices were built around these treatments. House calls were common for wealthy women. Discretion was paramount. Others sought treatment through hydrotherapy, specialized water cures that used directed pressure to achieve the same effect. European spa towns gained reputations for restoring feminine vitality through scientific means. Patients often attended weekly sessions for years, and here is where the story becomes truly unsettling. Despite the consistency of results, despite the obvious physical responses, despite the unmistakable relief, doctors never connected these treatments to sexuality. Medical textbooks either ignored the clitoris entirely or dismissed it as biologically insignificant. This was not ignorance in the absence of information. It was ignorance maintained by belief. The idea that respectable women could experience sexual pleasure was incompatible with Victorian morality, so the evidence was reinterpreted, renamed, and filed away. When Joseph Mortimer Granville invented the first electric vibrator in the 1880s, his motivation was not pleasure, it was efficiency. His hands were cramping. His wrists ached. He needed a mechanical solution. The device dramatically reduced treatment time. Although Granville claimed his invention was intended for muscular disorders, other physicians immediately adopted it for hysteria. Medical journals praised its effectiveness. Manufacturers produced dozens of models. Catalogs marketed them as essential household appliances. By 1900, vibrators were sold alongside sewing machines and lamps. The irony is almost unbearable. An object now associated openly with sexuality entered homes under the banner of health precisely because sexuality was denied. Doctors like John Harvey Kellogg, famous for his moral crusade against masturbation, used vibrators in their sanitariums without ever acknowledging the contradiction. The same man who condemned self-pleasure as dangerous regularly prescribed mechanical stimulation as therapy.